Hello, I'm Nurse Linda, and welcome to the Christopher and Dana Reeve Foundation. This is the Ask Nurse Linda webinar, which you can ask any questions. A lot of people have already written in their questions, but the question and answer box is open if you'd like to write in a question. So welcome, first of all. Be careful with all the heat that's going on, and for our friends who are out on the West Coast and in the state of Hawaii, please be careful because we have that tsunami coming today. So it's all over the news where I am. So I can't imagine what that must be like. But anyway, welcome um, and stay safe. I am a lightly pigmented woman with brown hair that doesn't look as gray as it truly is on camera, but there's some strands in there. I wear some clear glasses for reading. Um, I have on a burgundy shirt today, so I thought it would stand out a little bit against the background, but it's kind of blended in a little bit. But anyway, so I'm a talking head today. There were a couple of questions we had. The professional webinar was on today about, or was on this month about pressure injury and a group that's starting a pressure injury awareness campaign, which is really wonderful because, and I can attest to this. People live in the moment of the bowel and bladder issues, which come up frequently, or other health issues like autonomic dysreflexia, and they live in that moment. But pressure injury is something that a lot of people think that's never going to come to them, but it is really something that we should be aware of all the time, because the most important thing about pressure injury is doing your prevention so that you don't get one. Because once you have one and it heals, your skin is not as elastic as your original skin was. So once you have one, you have a higher chance of yet having another one. Another myth is that a lot of people think that um, if they're on a pressure cushion, that they can't possibly get one because that will keep them from having a pressure injury. There is no pressure cushion, no pressure device that can prevent you from getting a pressure injury. You still have to do pressure releases, you still have to move your body, you still have to do certain things, so you have to be cautious. Now, younger people who maybe have healthier skin, who maybe have more muscle mass, they take a little more risk. They don't have a pressure injury, so they think, "Oh, I'm fine, I'm fine." But as you age, your skin becomes less elastic, thinner, your muscles become thinner. So these are just kind of things that you need to think about. It's not like I have to think about my skin all day long. I have to check my skin all day long. You do have to do your skin checks. You do have to do your pressure releases, but it just becomes second nature to you. So that's the goal, is to just it's just incorporated into your part of your life, so it's not so overcoming to you. I have to do this, and I have to do, I have to do all these things in these different time zones, uh time time restrictions. So just think it's going to become easier as you go along. You get adapted to it, your limitations, and it will all be fine. In the end, it will all be fine. So there were a couple of questions that we didn't get to answer because they weren't particularly about pressure injuries. So I want to answer those questions now from that webinar. So this somebody wrote in that their son recently became non-ambulatory. Any suggestions for new non-ambulatory care? And so, that is a huge blow, because being non-ambulatory does not mean non-movement. So sometimes you have to provide movement to the parts of your body that are not moving. Being non-ambulatory does not mean that you're laying in bed all day. It means you can still get up in a wheelchair and you can still get around. You can still go out in the community. So keeping up with your active daily life is very important to, maintain your social contacts, be sure you're getting out in the world. Harboring in your house is not really a place that is going to keep you mentally healthy, because we all need people in our lives. We all need to see other people. We all need to get out, get a change in environment, go out in nature. We all need to be doing these things. And just because you're at non-ambulatory does not mean no movement. So be sure if you cannot pick up your leg and do your range of motion or your stretching exercises, be sure that somebody is doing that for you a couple of times a day because that helps keeps your muscles pliable and your nerves pliable. So it just helps with a lot of things. Also, something that may be very helpful is to get a standing frame. Now, not all, but very much most payers will pay for a standing frame. So check with your healthcare professional because you'll need a letter of medical necessity to apply to the insurance to get a standing frame. You also want your healthcare professional to check you to make sure your bone density is strong enough for you to stand on those legs, to make sure you don't have any blood clots, to make sure that you're healthy to do standing. That puts pressure through your legs so you can avoid a lot of things like you can avoid city. It gives you different perspective because now if you're not ambulatory, you're not standing upright. So it gives you that opportunity to assume that position. So it just does a world of good. And you can get a standing frame, stand in it for an hour, and you can do other things while you're in the standing frame. Some of them have little wheels that you can wheel around the house or your workplace in your standing frame. Some have a glider like you see on TV, like a skier, those glides that go back and forth. So you can exercise your legs while you're in the standing frame. So there's a lot of options here. So just because you're non-ambulatory doesn't mean you can't get up and get around in the world. Now there are some wheelchairs that will help you that go from sitting to standing and back and forth. That they can be a bit more of a challenge, but if that's something you're interested in, work with your healthcare professional. You can keep applying. Remember, if you're denied, that you can always appeal and keep appealing until the case is closed. The case is either closed because you've gotten the product you want, or the insurance says, we are just not going to pay for this. And then you have to start looking for alternative paying mechanisms, which can be a challenge right now to find those places. But there are people in your community, there's all kinds of um, uh, options that you can have for getting equipment that's denied through your insurance. But go through your health insurance as long as you can and keep appealing, keep appealing. Just because you get that first letter that says it's denied does not mean it's denied forever. So keep working on that. This other person said they had a spine injury at C45 in 2021. Now they're experiencing numbness in their hands and feet. So, if you had spine surgery, it depends on the source, the cause that you needed the spine surgery. So, if you had spine surgery because you have a disease, it could be progression of your disease, or it could be something in spine surgery. Maybe there's some swelling, maybe something's pinching on something. So, if you have numbness in your hands and feet, you want to be sure and check back with your surgeon, have them do some radiological procedures to make sure everything it is as it should be to get to the source of what that is. So that's a pretty important thing to check on. Now we do have some questions on today that have been submitted, and as I say, just go down to the bottom of the Zoom screen, and towards the bottom of the screen above your toolbar, put your cursor there, and you will see some boxes that come up, and there's a box that says chat. And so you can put something in the chat box or you can put a question in the Q&A. So I know that somebody wrote in and said that they're having some trouble getting their questions typed in fast enough during the Zoom session. And that I know because that would be a challenge for me. By the time I get it typed in, they've moved on to something else. And then you think, oh gosh, they're going to skip over me. Well, we have a tendency to swing back to these things. But if you have a question during this session, you can type it in, or you can go to the Christopher and Dana Reeve Foundation, go to the home page, scroll down to the bottom of the page. There's a little blue button there, and it says Ask Nurse Linda. You can click on that button type in a question and it will come to me and I will answer it. Since I do this all day. So just go ahead and do that. We also have information specialists at the organization that you can contact the information specialist and they can pretty much answer any questions. They're very efficient at what they do. They have a huge knowledge base and we do all kinds of paralysis. It does not matter what your paralysis is from. Now, Christopher Reeve, of course, was associated with spinal cord injury, but the foundation has grown to include all paralysis. So it could be head injury, it can be stroke. We have a lot of people that are writing in for information about what to do. Now, I've had a stroke. What do I do? So there's a lot of people in that group. There are also people who have neurological disease, Parkinson's disease, um, just multiple sclerosis, ALS. So we get lots of questions from a lot of people. Doesn't matter the source, we're here and we're ready to answer. So now let me just scroll down to see if there's any questions coming in, and I don't see any right now. So I'm going to start with these questions. We've got a lot of information in the chat. Remember, all of these are everything from the Reeve Foundation that's on the Zoom gets put on the YouTube channel. So if you're interested, you can't come to the session that's live. That's a lot of people, it's a lot of people out in the world. There's not a time that everybody can attend. But you can always go onto YouTube. You don't need an account or anything. Just type in YouTube and then type Christopher and Dana Reeve Foundation, Nurse Linda, and all my webinars will come up. Those include the Ask Nurse Linda question webinars. They're dated, so you'll know which one if you've missed one. And it also includes my professional webinars. So if you go back, you might see somebody that you want to hear talk about some topic. So what I do in the professional webinars is I interview people who are at the top of their career in studying something about paralysis, and they go in depth about what they're doing to study that particular topic. I find each and every one fascinating because, of course, I love my job, so I love hearing about this. I can never get enough of it. So be sure and tune into some of those. You'll see some that are really fascinating. So our first question today is an individual who has a T35 complete injury for 56 years. So congratulations, that's quite a record. And as you know, people with paralysis, especially in the spinal cord injury group, can live the same lifespan as people who do not. There's some caveats, but the life expectation is just the same. And I think I need to say that several times because a lot of people think, oh no, something, I have this, so I probably die earlier. No, not anymore. There was a time, but not anymore. So you're right up there. They have significant torso movement. They've been doing some treatments. Now they have some torso movement, but now they're getting the phantom pains. So they're having to take tramadol. So that's medication to help control that. He wants to know what he can do naturally. His body and legs are involved. And one of the simplest things that everybody should be doing is to move their body. So the body parts that aren't moving or that aren't moving in the full range of motion of the body, be sure and exercise those body parts. Now, it might be a process of, moving your hands, doing your stretching exercises. You can go online and get stretching exercises. I'm sure we'll have a book about that, how to go through the range of motion. I did a blog about that, going through every single joint and how the joint moves. So if you can move your finger and you can move it down, you can move it back, you can move it in and out. Be sure and do that. Now, you don't want to move your finger back to the back of your hand. You'd be breaking your bones. But in that little blog that I did about this, it would say, your finger moves a little bit back, it'll move all the way down. Your body wants to pull towards your body. The muscles that pull towards your body are stronger than the muscles that push away from your body. That's why you'll see people who get contractures where their muscles have tightened up and they can't move them because they're so tight and they aren't able to exercise these. That's what happens because these muscles need all your muscles need movement and they're craving movement. So you have to supply it through other ways. So movement is the easiest way. I was talking about the standing frame. That's another thing that holds your body upright. So it gives your body a different position, but it has all kinds of benefits for breathing. Standing upright helps your bowels move because you're not seated, you're not laying down. It helps your bladder have some shaking of the bladder when you have some movement. It certainly helps your bone density. So get a standing frame, as I say, almost all in authorized for you because the benefits are so great. Aquatic therapy is something that's often overlooked for people who are having phantom pains or having spasticity, which we now call clonus, but most everybody still calls it spasticity. But if you hear somebody talking about clonus, that means spasticity. So, aquatics in a heated pool, if you get into a cold water pool, it's going to freeze your body up. Just think about you get in the cold water. What do you do? Wow, this is cold. So it cramps your body up more. But if you can find a heated pool in your community, you might have to call around to find a heated pool. But in most communities, in larger communities, you're going to find one. Now, is it going to be close to your house? I don't know. Is there going to be a fee? Maybe. But there are different places that you can call around and ask about swimming pools. Do you know of one? Ask people in your community. Um, you know, there's all kinds of places to find those. And as I said, get warm water because if you go in a cold water pool, that's going to cramp your muscles. Your muscles are going to react to the cold temperature. So it's going to make things a little harder. We do have a question that came in. Is it ever too late to use a standing frame? The basic answer to that is no, but you do need to check with your healthcare professional because they need to check to make sure your bone density is strong. You don't want to stand up on bones that cannot support your body. This person hasn't stood for 15 years. People who haven't stood for a number of years can get into the standing frame and work towards using it. Now, you might not be able to pop up in the standing frame right away. Well, first of all, let me tell you, a standing frame, you transfer from your chair into the standing frame in the seated position. So you're sitting down. You might need help, somebody to help you get in there. Okay, so you're sitting down, and then there's usually like a lever on the side that will pump you up into a standing position. If you haven't stood for a long time, your heart might not be able to pump your blood to your head when you go to the standing position. We call that orthostatic hypotension. So you might need to get into the standing frame, sit there for a few moments, just sit there, get accommodated, maybe do one pump and then see how you're doing. If you pump yourself completely up to standing, you might pass out. Some people will and some people won't. So these are some of the things that your health professional needs to check about these things. Make sure you don't have any blood clot that's going to be dislodged. So they'll do a whole physical exam and they'll say, yes, ready to start the standing frame. You get the order from your physician, it goes to your health insurance, and then they start processing that. So just be sure. Oh, my friend Peter is online. I love it when Peter says things. He has the most helpful comments. So thank you, Peter. He said, yes, he hated the pool for PT. He was in a heated, where that it's, I think he means he was in a heated pool for PT yesterday. We had a win with some leg movement on a reciprocating gait. Yes, absolutely. The buoyancy of the water helps support your body. If you look at Christopher Reeve's recovery, he did a lot of aquatic therapy. And a lot of people want to say this is not true. And this is true. I saw it with my own eyes. I was there when it happened. So I was there with a lot of his aquatic therapy. Now, he did require people to help hold him up, but after doing aquatic therapy, it wasn't quick. It wasn't easy. And, he had the ventilator, so we had to be very cautious about being sure no water got in that. It was, for us, it was kind of like, yeah. But anyway, he was determined and he could walk in a therapy pool. Now, that's not a standard Olympic size. That's a smaller pool. So maybe like 20 feet. Maybe it was a little longer. I'm not good with those kind of measurements. But with people just to help support his body, not to necessarily hold him up, but to support his body because of the proprioception. And so knowing where your body is in space, he could, with support, but nobody helping him walk, he could pick up his feet and walk from one side of the pool to the other on his own because the buoyancy of the water lift his legs as he was moving along. And so, yeah. So, Peter, good for you. You'll be surprised what that pool could do. Now, you might need to go to a therapeutic facility before you get into the pool. I know I have some people who've talked to me about pools. They have a pool in their backyard or, and they wait for the sun to heat it up. That's usually not warm enough. But, for them, it happened to work out. So, people will do different things. Sometimes public pools will have some people who do aquatic therapy working at certain days on the public pools. I always find it very helpful to call the MS Society because people who have MS have problems with cold, just cold air, cold wind. They probably have problems with the cold. And so the MS Society always knows where a heated pool is. If you have, that's a good place to just call. And it doesn't matter if you have MS or if you have paralysis for something else. That, it's not an MS program per se, but you can usually find a heated pool through that. Here's a person who has two questions. They want information about stem cells and the walking robot. So let's talk about that. So, stem cells were the big thing in the 1990s. This was the cure. It was coming. Everybody was working on it. They're still working on it. It's just a lot more complicated than we thought. So that was an issue. So it's taken a lot longer, but it was the big hype. It got into the news. It was well talked about because it got political. It had nothing to do with political things, but anyway, it got all confused with a lot of things. Well, just recently, Mayo Clinic did a stem cell transplant in an early study that was somewhat successful. And so they made a lot of headway on that. Now they've done a lot of work because it was getting the stem cells, first of all. So if you got a stem cell transplant from somebody else, like, if you have cancer, they'll give you a stem cell transplant from a donor. But people who have spinal cord injury have a lot of immunity problems. And so to take the stem cells at that time, not now, at that time, you would have to take immunosuppressant therapy, and you're already immunosuppressed. So that puts you at risk for other things. So that became complicated. Then came the issue of how do we get the stem cells into the injury, if it's in the brain or the spinal cord, because you have to go inject through healthy tissue. And if you're on the ventilator, especially in the spinal cord, your body is still breathing up and down. You have movement in your chest. So, how do you inject that while your body's moving? So, they developed a technique to do that. Okay. But you still had to put that needle through healthy tissue in the brain or in the spinal cord. So, you had to inject. So, that was making a needle hole in healthy tissue. So, what did we do about that? So there were a lot of things. And once you got the stem cells in there, would they stay in the area of damage? Would they grow outside the area of damage? Would it cause pain? So they worked on that. And then once they got into the place where the damage was, would they multiply? And then usually when you have damage in your nervous tissue, a scar grows around it, just like your skin. A scar will grow around that area. So how will the stem cells get through that scar to connect with the healthy tissue? So they had to work on that. So you see it's very, very complicated. They even developed, if you can imagine, like you see scaffolding when somebody's painting a large room or when they're going up in a building, you'll see scaffolding. So they had developed little tiny biological scaffolding for those stem cells to grow within the injury area. So you see, and that's just cutting the top of the surface. Now, some people have done some stem cell work, legitimate stem cell work with putting it in. And some studies have had some positive outcomes, but they also have had some negative outcomes. So they're working on how do we work out some of these negative outcomes. So the study that was recently done by the Mayo Clinic is what they call um, a level 1 study. It's done on very few patients. It's just done for safety. So they've done it on animals, they've done it in the laboratory. Now they're moving to humans. We just want to see if we do this just for safety. It is not for any kind of cure. It's just to see if we put this in somebody, will it harm them? Or even will they die, quite frankly? So anyway, everybody survived, so that's good. So that's just that phase 1 study. Then they'll move to a phase 2 study, which is more to study um, dosing. Will a little do good? Will a lot do better? What should the dosing be? What other treatment should we have that goes along with this? And then they'll move to phase 3, which takes in large bodies of people to look for how this works, to get all the kinks work out of the plan. And they might go into a stage 4 study where they're looking at different aspects of the study, working things out. Now, each of these 4 stages can have stage 1A, stage 1B, as they develop this along. So it's a hugely long process, but we have to make sure it's safe for people. And so we're making strides in there, but we're not there yet. The next part is about the walking robot. And this is a device that has been invented. There's several companies that do it. It's like a battery pack that you wear on your back, and then it attaches to some braces and a harness around the waist. It's done for people who have lower level injuries, some people who have brain injuries, some people who have neurological disease, and that is all of a piece to the puzzle. It is only authorized for exercise use. You can get one in your home, but it is legally not authorized for you to just go like walking around in the community. You have to have somebody who's walking with you for safety, and it's only for your daily exercise. However, our friend of the community, Ashley Barnes, who's a very good friend of the community, has worked diligently to get this all authorized by Medicaid. So if you have Medicaid in most states, you can get one of these um, robotics to use for standing and walking. It's not like walking like you had before. The pack's very heavy. Going up and down stairs may be a challenge. There's all kinds of different caveats to it. But if you're interested in that sort of thing, that would be something to talk about. Now, we have a question about another study, and so I'm going to skip ahead because there was a question about that. So let's just talk about studies that are going on right now. And one is about this NVG 291, which is a peptide that goes into your body and it stops the natural healing process. Now you think, wait a minute, I want to heal. I don't want it stopped. But now this is something that a lot of people don't understand. Okay, if you think about your skin, because we can see that. You get a cut on your skin, you can see the opening on your skin, and you see the blood rushing to the area. It might get a red around if you get a cut on your skin. Um, you might have some little tiny bit of swelling around the cut. You might have a lot of swelling because those are factors. Those are factors in the body cells that's being rushed to the body to close that wound and to heal that wound. That's the natural healing process of skin. there's a natural healing process in the nervous system that will want to wall off that problem area where the spinal cord injury is, where the brain injury is, where the stroke is. If you have neurological disease, it might go to different places in the body that will want to stop that because your body thinks we don't want this to spread. We want to wall this off. We want to contain this. This is a problem. Something's wrong. We want to contain it. So that's what we call the natural healing process, but that makes it more difficult to get different healing factors into that area. So the NVG 251 is a study to help slow down that natural healing process because it's preventing our treatments from getting to it to heal it. We don't want it to just wall off. We want to heal the area. So we want to kind of change the healing process, so to speak. It's very complicated. It sounds complicated because it is. Anyway, that particular study is in a phase 1B. I was telling you about the different levels. So that is now in a 1B phase. So now they're still looking for safety. They haven't yet demonstrated that this is safe to do in humans. So they need to do some more testing, maybe different dosages, maybe different additives. There's a whole lot of things that this could include. And they're looking at the 2A studies, which means looking for just getting right into the dosage. So we're in the process of going from safety to dosage. So they're moving ahead. So it's 1A and it's 1B and 2A. So it's right in the middle of these early trials. In these early trials, they're only using a handful of people. This is not a widespread study like when you get into stage 3. It's a lot more people. This is a small number of people, but they're making progress. So we're getting a lot of progress, a lot of places. The other person had the issue with the stem cells. We talked about that. Nerve bridges is another thing that they're asking about, and that's where they're taking cells from up here in the nasal cavity, which is also coincidentally the most plentiful place where you have stem cells. So they'll go up, not, you can't just take, like in the COVID test, you can't just take the swab up there and gather these. They have to go way up in here. So it's usually a general anesthesia kind of process to get those. Now they'll improve that over time, but it can be, it's not necessarily like a super dangerous kind of procedure to have done, but it can be painful to, have people poking way up there around in there. So they take those nerve cells and they grow them in the lab to make a bridge through that walling off through that place where the neurological injury is. So that's what they're talking about, is bridging around that. So if it's already walled off, can you bridge around it? Can you make the bridge go through it? These are all the kinds of things that are going on with that. And then the other one was a question about implants, because this is kind of interesting because, we started off, I go back to Christopher Reeve, and he did the functional electrical bicycling, which was putting electrodes on your skin and it made your legs move to ride a bicycle. So it gave you exercise, but it also had a lot of other health benefits, and it still does. So it's a wonderful treatment. It's a challenge to get the bikes because they are expensive, but it's a good treatment. But in the meantime, that has progressed, and so they did implants for nerve functioning in the brain and in the spinal cord. It didn't matter what neurological injury was, but they were looking at, they would pick one kind of injury to start with and work these things out. Well, now they've advanced that, and they have a patch. It's really like a big strip of tape, and it has electrodes in this piece of tape, and they on your neck, which can improve hand function. They put it on your lower spine, which can help leg movement, bowel and bladder, sexual function in men. Not so much in women. Women's sexual function is a big mystery. For men, it really helps with erection, is what it does. And so these this process has been now approved um, for sale through companies called Onward and Spinex. And so they're selling these, and they're in market. But now they have the process of getting people educated, so they're available in local communities. But they have a plan, and in a year, probably 2 years, you'll be able to go to your local place and get this. It's just a strip that goes on the back, so you don't have any worries about surgery. You just wear this wherever you want, the most function. And so it's really quite a nice thing. And they thought that when they started the process, the studies, the different level of studies, they thought it would probably take maybe 6 months for people to really get this. And it's turning out it's a matter of a few days or a few weeks. Some people get the patch on and they're like, oh, okay, my hand moves. The interesting thing about it is when you turn this device off, there's a hangover period. So when you turn the device off, you're going to go to bed, you turn the device off, you still have function for a short amount of time, depending on you and your injury. There's so many variables, but you still can have some function a little bit after the device turns off, which is kind of cool. I've seen some people that have done it, have been in the clinical trials. They were in the clinical trials, but then the device got taken away from them because, they were in the study. So they had 6 weeks of a clinical trial. But I have seen people who, finished the clinical trial and they were left with increased movement than they had before. Not as much as they had with the device, but I know one gentleman, and he knows who he is out there. I'm sure he's listening. And I would see him at different events, and his hands were always flat, just flat, no tone whatsoever. He'd be sitting in his wheelchair. Somebody would have to give him a drink. His hands just sat in the wheelchair. He had it for 6 weeks. He does not any longer have the device, but he can feed himself. Now, this is an unusual case. He didn't lose total function. It's not like it was before his injury. It's not like it was with the device, but he did not lose total function after he was through the trials. So there's a lot more coming with these kind of things. So can you imagine that you could have increased function, not the same, but increased function by not even having surgery? How fabulous is that? So there's just a whole lot of things going on. And we're going to be talking about um, uh, more research on the professional webinar next month in September. I forget the date, but look for it because we're going to be talking about all these research things. Here's somebody who was using the exoskeleton for a while and then his spasms got worse, and the therapist said he could no longer use it. I'm sure there's reasons, but she thought exercise was supposed to help spasms and what could cause spasms to increase. And yes, you are right. Exercise does help spasms, but sometimes the spasms become so strong they overpower. There's a couple of options. You can treat the spasms with Botox injections, with oral medications that would help him get back into the device again. The good news here is, and this is a backdoor good news, but when you have spasms, they interfere so much with people's lives, and they can be painful. They can throw people out of their wheelchairs. They can become so severe. They can be real problems that people don't like to be spasming when they go out in public. People get embarrassed by it. It's a part of their disease. We all know we shouldn't be, but we all get embarrassed by things we shouldn't really be embarrassed by. But, there are things that, that's human nature. So what a spasm is a miscommunication of the nerve. The nerve is the muscles are trying to send a message through, and somehow the message is getting through, but incorrectly. Yikes. So the good news is a message is getting through. So the spasms, and I'm just free thinking here, the exercise, because he was using his muscles, and his muscles are saying, "Hey, I like this," and he's getting return of function because he's having these spasms, but the spasms are stopping the exercise. So the thing would be to try to control the spasms so he can get back to the exercise. It's a good news, bad news. And I hate to say this because it's like, what do you do? We're in a catch 22. Yes, you are definitely in a catch 22. But if you can get those spasms under control just enough to get back into the exercise, it can help him move forward in his recovery. So don't give up on it. You got the device. Talk to your healthcare professional about controlling the spasms, figure out the best treatment for him, and see if you can move forward with that because, or maybe you want to move on, to the strip of tape or, all these different things that are coming on. But, it, I want to say to you, Laura, this was a good thing even though it's turned out to be, an impediment. We have all kinds of little bumps along the road. This is a bump along the road. So he's getting better, so wow, that's really fabulous. Even though it's a bad news story. Okay, we talked about how you can get this on YouTube. Oh, here's somebody, we have this question so very often. It's about excessive sweating. Most people who have neurological injury do not sweat in the area of the neurological injury. There are a subpopulation of people who sweat profusely. Again, it's a confusion of communication. The body's trying to fix something. I'm not getting messages why that part of your body is not sweating. So the brain's going to send all this stuff to that body part. And what happens is they sweat. And I mean, it's a drenching sweat. It can be dehydrating. So there are treatments. Now, if you're just sweating in one part of your body, like if people who don't even have neurological injury, but some people have just sweaty palms or sweaty feet, there's a treatment called Iron, iron, iontophysis, ionotophysis. Sorry, I get talking and then I can't talk. And you put your body part in like a tray, and they send a little electrical current through the water. It's not going to electrocute you. It's a controlled type of thing, and that helps stop it from happening. But you might have to have that done a couple of times. You might want to use a Botox injection that helps slow down the sweat glands in that particular part of the body. You might, if it's like a large part of the body, there are anticholinergic medications. Those are medications that people take for all different kinds of reasons. But one of the things is that it slows the body, so it slows the production of that sweat. And a lot of people have uh, um, good results with that. There's an opioid that I will not recommend. So I'm not even going to mention its name because, there's too much addiction. Opioids are addictive. If you are in the situation where nothing else has helped, talk to your physician because you will become addicted to it. Some people choose to be on addictive medications because it's helping them. I'm not recommending this. This is a far out thought. Talk to your healthcare professional. There are topical creams. I don't think that this would help in a neurological process, but if you have just a little bit of sweat, there are some topical creams that help decrease sweat production, antiperspirants. They stop the perspiration, but not when it's like this drenching kind of thing that people with spinal cord injury have. Um, you can use coolant towels to help cool your body if you're out, if it comes from heat. We were talking earlier, I brought my little neck fan, which I find quite nice. It has some holes here that blows out. I like this because if you take towels that are cold and you put them in this is really inexpensive, so it's nice. You can get some towels, put some water on them, put them in a cooler, put some ice in there, the cool towel, put it around your neck, but it's not around your neck. Put it on your lower body to help keep your body cool if you're outside. You want to look to make sure that they're not too cold. You don't want to put ice on your body because that's going to give you the frostbite. But something that I have found that I use, and I don't have neurological disease, but I use this because I just get hot and we're in a heat dome. The temperature today at my house feels like 108. And so to go out to the mailbox, I put on my little cooling fan to go to the store because this blows out cool air, but it doesn't blow out too much cold air that I get frost. You can buy these pretty cheaply. There are some that are hugely expensive, but you can buy these online. You can go to the store and buy them. This one costs about 30 bucks. I have seen them for cheaper. You power them the same way you do your cell phone, so you don't have to keep buying batteries. So it's kind of a nice thing, but you do have to watch to make sure your hair doesn't get caught up in this fan part where it's blowing out. You just put it around your neck and it blows on you. And let me tell you, it does keep me cool. So I have to say that, but I never recommend any products, any one, they're all the same. The cheapest one you can find is good enough. They are all pretty much the same. Um, let's see. Somebody lives at a college campus and they have a nature center, but it's really not accessible to them in their chair. Can they do about this? Well, talk to administration. There might be some ADA rules, some compliance for making it. Maybe they can improve some way, put some paths down, maybe some paths, because being out in nature is so fulfilling. If it's open to the public, that might be a draw for the university to put some, or the college to put some money into that. Another thing would be to start a campaign with alumni, talk to the foundation at the college. I'm sure they have something. Somebody might want to donate some money to doing something like this. So there's all different kinds of ways to get these kind of programs going. It just takes somebody. I think it'd be just a terrific idea to make the walkways more accessible, to do some kind of opening that up to the public, to, for more people to enjoy it as a community kind of thing. So, you just need to get the ball rolling, because unless unless you're in a chair or you have somebody close to you who's in a chair, people just don't ever think about that. So, just maybe didn't even give them pause to think. So just suggesting it, oh, that's a good idea. But oftentimes, colleges and universities have foundations or people who want to donate money to a good cause, and that would be a great cause. There's a person who wrote in, I get dressed in bed. Does anyone have suggestions for getting rinsed off and change into clothes? It would not be good for my wheelchair cushion either to be used when soaking wet from the pool. Ah, I see. Okay. Um, so it can be, yeah, yeah, you go to the pool and you need to rinse off after that. So usually in pools that where people go, there's usually like an accessible lift or chair. They sometimes have a stretcher where you can and lay on the stretcher, or they might have a portable um, I want to say something like a commode chair with a cushion on it that they can wheel you, hose you off, and get you dry. I know when in institutional pools, they'll have a stretcher where they have somebody lay on the stretcher where they can, get the pool water off of you and get you dressed on that stretcher. Some people will sit maybe in their wheelchair just for that trip from the pool to getting changed, and put some plastic over their cushion, which makes the cushion not as effective because it's not going to have the cushion part. It's going to have that plastic over it. Some people will use a chucks on there to capture that water. So there's all different kinds of things that people do. But that's a good question, because that's one of those things that you don't stop and think about. Here, somebody said they wrap their cushion in a plastic garbage bag, while they're going from hither to yon. So, if you're going to do that, just very, very briefly, always check your skin. Don't do it for a long time, because the water's not going to be held there and you could get an infection or a rash, and nobody wants all that kind of stuff going on in their body. Okay, so we've got a few more questions. Um, Some of these I've already answered, so I can, ask Nurse Linda, use that blue button. There's a person who wants care for children with spina bifida after surgery, and we have some information at the Reeve Foundation. You can go in and look at the Reeve Foundation and look up spina bifida, and it gives all kinds of information. There's information pages about different diagnoses. And so that gives all kinds of information about caring for children with spina bifida from start to finish. And so that's a good place to go. There's also the Spina Bifida Association, which we partner with a lot of times to do different things. Um, Spasms that are so bad that drain energy and impacts us sleep. We have the spasm booklet. I think I saw it come up because we talked about spasms, but movement, medication, injections, there are treatment for spasticity so that you can help get that under control. Um, oh, and then the other question was transitioning from assisted digital stimulation to a self-directed program, and this was for her son. So parents usually start out, caregivers usually start out doing the bowel program for the person. Now, this person has an injury at T6, T7, so they would have some hand function. So it would be perfectly, um, they would be able to do their own bowel program. Different people with brain injuries or head injuries have different levels of function and make it a challenge. But for this person, it would be good. So talk to your son about what you're doing. That's usually the first step in the process. Let them know what everything looks like. This is what I'm doing it. This is why I'm doing it. Get them accustomed to what it is you're doing it. I tell people who have young children to, when you're catheterizing, when you're doing the bowel program, when you're checking the skin, just talk to them about it. Even if they're toddlers, talk, this is what they're doing. Get them involved. Here, look at your skin with the mirror. This is what the suppository looks like. And now I'm going to put some lubricant on there so that it goes in easier. I'm going to put this glove on, so they know all the steps. So get them to know the steps, understand what it is you're doing, why it is you're doing it, all those different processes, and then eventually work with them. Okay, and you start by gathering the supplies. After you've talked to them, we've negotiated this process. Okay, you start. Okay, let's just practice today on inserting the suppository. That'll be the only challenge. Okay, you've got that done because it needs to go up against the wall of the bladder of the bowel. So make sure that, they know, you're not just sticking it up there because it won't melt and you won't have a successful bowel program. And just go through all the steps and gradually just transition until they can do it on their own. So just go step by step. And the bowel management booklet goes through the step by steps. So just work it out, through the process. There's a chart in there that tells, all these different little tips and tricks so that it's always going to be successful, and just work with them until they're comfortable in doing that. Now, since has a level where he'd be able to do this himself, he might want to do it on the toilet. If you do it on a toilet, you might want to buy one of those seats that has the opening in the front. So sometimes people will reach in through the front. If you do it on a commode chair, a lot of people don't know that the seat on the commode chair, which usually has an opening in the front, um, that seat can be turned so the opening is in the back. That can be kind of hard to reach around to get to the back. Some people can do it, no problem. It can also be turned so the opening is on the side, so it's easier for them to just kind of move their body a little bit so the arm is protecting them from falling over. You want to be with them the first few times they're doing this to make sure they don't fall. And it's an easier reach to get to that area. And as they get more progressed in this, it becomes easier and easier and they become used to it. It's important that you learn is as a caregiver that this is nothing unique. It's the way that this person now toilets, and it's the fact that they need to, this is the way that I toilet. Now, as I say, we talked about all this research that's coming down the pike. this tape, I just call it the tape thing. This tape thing that's coming, is helping people with bowel and bladder function. This is not going to be, it used to be, we think, okay, well, now this is the way it's going to be. I personally, and this is my personal opinion, do not believe it's going to be this way for that much longer, but it is this way today. So we have to take care of ourselves today, just like everybody has to take care of ourselves today. And so, it's not like, oh no, let's not wait until this comes. If you have a child, a teen, even as an adult, and they're capable of doing their own bowel program, they need to do their own bowel program. Okay, so a parent or a caregiver of a person who doesn't do a bowel program doesn't have somebody come in and watch them toilet. You do it because it's needed, and when they can do it themselves, it's up to them to take responsibility for their own body. That's just a part of adapting, and this is the way it is today, and you'll get through it. You'll get accustomed to it. Yeah, I have yet to meet the patient who said, when I go in and explain a bowel program to him, says, "Oh, great, I've been waiting to do this my whole life." Most people are like, "You want me to do what?" It's a shock to the system. But if you treat it like it's a normal process, they're going to treat it like a normal process because this is now their normal. So that's just a good, kind of little jolt to the brain to know what to do. Now, there's a couple of people who are looking for help. There's somebody who's in the father who has a father who's they're trying to get help for their father, and they've been to the rehab, and now he's back to the hospital. And there's another person who has Charcot-Marie-Tooth type 2A, which is a neurological disease. Uh, I'm all too familiar through the MDA Society, and they're no longer to do their care, and so they're looking for help. Now, we talk about this quite frequently on the program because it's very difficult, even if you have somebody that you can find to hire to come and do the care. It's almost impossible to find somebody who knows how to catheterize, who knows how to do bowel programs, even if they come from an agency, even if they're a nurse that's been practicing. The care for neurological disease is so very specific. The rehabilitation care is even more specific. And so people don't know. So you become the family, the patient becomes the educator. The patient needs to know what their care is. It's hard to find individuals once you get them trained and you get along and everything's going fine. You don't want to, you want that process, but they have days off when they're sick. Different things happen. And so it's really hard to find people who can come in to help. It's even harder to find some kind of payment system that will pay for this help because basically there's not much, even for high level people who are on ventilators. The payment is not 24-hour care through insurance or through Medicaid. It's just, unfortunately, it's just not the way it works. And that's a shame, let me tell you. So it usually falls to the family. And some people are quite shocked about this. Oh, I have to provide round the clock care. Well, maybe there are things that they can do. Now, the one person writes in that they have uh, Social Security disability. You might still qualify for Medicaid. Always look into Medicaid and see if you qualify. Check your health insurance. There usually is some kind of uh, something, unless the person's predicted to be independent. And then it falls on the family monitoring, getting up at night, doing the turns, doing the catheterizations, doing the bowel programs, monitoring the ventilator. A lot of this falls to family, in which case you might want to ask if there's anybody in the family who can help. If there are people, sometimes there are people in the neighborhood. Sometimes you might know a nurse that might be able to help. There are different people who are willing to even just, could you come over and just stay with my person? They won't need anything. They won't need any care while I'm gone. and just so I can, like go to the grocery store, or they'll say, "Oh, I'll go to the grocery store for you." But as a caregiver, you need to get out sometime. And if it's going to the grocery store, if that's the first step, then that's what you need to do. So it's looking around at the resources, trying to figure out how you can manage this, but check with your insurance provider. There should be something in there. If that person is, you know, quote unquote, moving towards independence, it probably won't be. There might be some home health care that you can get, which would be having somebody come in and they can help with some of these things. It would be for a limited amount of time. That I hate to end on such a sad note, but that is a sad note. So we have to work. Um, we have to get involved as family members. We have a wonderful advocacy program at the Reeve Foundation. You can look them up on the webpage and find out how you can be involved. If that's sending letters to your Congress people, that's an important thing to know. They need to know that, we need help with this sort of thing. But anyway, as I say, things become routine over a while. It can be so overwhelming when somebody first leaves the hospital and all the different things that need to happen. And I'll get emergency calls. We're home. Oh my gosh, what am I going to do? Start out slow. Make a plan, a daily plan for yourself of what time these things need to be done. When you first start doing these things on your own, it becomes so um onerous that the plan that I'll just be now I do this. When do I get to go to the bathroom? When do I get to have a meal? It becomes just so overpowering. So just make your chart of everything that has to be done and do it. You'll find that things become easier as you become accustomed. It's like anything else. You go home and, oh my gosh, I've got the bowel program to do. Yeah, I did it a few times. Hopefully, you were educated in the rehab facility on how to do these things, but you never had to do the full day. And even if you did, somebody brought you a catheterization kit. Now you have all the different pieces. How you organize things. Give yourself a moment to think about these things, but give yourself some time to get in a routine. Then, as your routine moves along, you'll still know the things you have to do, but suddenly catheterization doesn't take 20 minutes, it takes 5 minutes. You get better at it once you get yourself organized, once you get your supplies organized, once you get yourself into a routine, it gets better and better. The more that the individual is able to do on their own, it gets better for them. But I know from working in different facilities, and you have somebody, it's the day they go home, they're fully trained, you have all the information. Um, they've done it, they've demonstrated, they know how to do it, and it's the day that they're going home, and the family member says to you, "But they're not walking. How can they go home?" Well, and you're sitting there thinking, we've told you this date for months, you've through all the training, but somehow it never clicked in their head, oh my gosh, I'm going to be responsible for this. So the sooner you start thinking about it, if your person's able to be responsible for themselves, the person with the neurological issue, if they can be responsible and they can direct their care, perfect. If not, you might have to step in until everybody becomes accustomed to this. And so it's a huge challenge. But you always have information from the Reeve Foundation. It will always be there and available for you online. Simple steps. Let's cut to the chase. So hopefully that will be the part that you need. You can ask questions. You can call back to the facility if you have a problem that comes up. You can ask the information specialist at the Reeve Foundations. You can ask Nurse Linda. We're always here to help. So remember that you've got options. So thank you for coming today. And boy, we sure covered a lot of territory. And I hope to see you next month.